Thanks, Dr. Ron, and thank you to the Riordan Clinic. This is an awesome event, and thank you very much for choosing this location. It's so awesome. Your hotel's right there, and you walk across the street. I'm so used to these things in Vegas where it's about a mile away from your room, but anyway, great venue, great to see a lot of old friends, and it's great to meet a lot of new friends as well. So I'll give you a little history first. I worked at the Riordan Clinic, then known as the Olive W. Garvey Center for the Improvement of Human Functioning International Incorporated, for 14 years, and I left in 1999, and for 11 years, from 1989 to 99, we had the RECNAC project, which is cancer spelled backwards, and that was funded by the Garvey family and the Page family predominantly, but we got a lot of donations from other people as well. And I had the privilege of working with Dr. Xiaolong Meng and his wife Fei Fei and Dr. Nina Mikarova and several other team members, Dr. Joseph Kashari, and our mission was to look for host non-toxic therapies for cancer, and one of the biggest things that came out of that, of course, was the vitamin C work, and we were the first to demonstrate that you could achieve cytotoxic levels of ascorbate in human blood that were toxic to tumor cells and not toxic to normal cells, and out of that we actually were issued three U.S. patents, and we never enforced those patents because we wanted it to be basically no more expense to the patient, because it's already expensive enough and most people are paying out of pocket. So that's a little bit of my history, but we also worked on cells, and most people here probably don't know that, but we worked on dendritic cell therapies, and there's actually a dendritic cell therapy that's approved for human use by the FDA from a company called Dendrion. It's for prostate cancer. It's not a very good drug, but it is approved because they were stuck with the technology from back when we started, which was basically in the early 90s. But that's where my interest in cell therapy came from, and I actually started a clinic of my own in 1999 in Arizona, and we did therapeutic cancer vaccines for cancer patients using dendritic cells. And we carried on that work in the Bahamas, and that's how I got interested in stem cells. So just want to give you a little bit of background on why I'm in cell therapy. It started at the Riordan Clinic back in the 90s. Dr. Hugh used to ask a question. He would say, "What's the most important nutrient?" Dr. Ron?
The one you're lowest in.
The one you're lowest in, that's right. And so how orthomolecular medicine relates to stem cell therapy is that holds true for your stem cells as well. What's the most important nutrient for your stem cells? The one they're lowest in. So orthomolecular medicine is huge. It is stem cell therapy. You're optimizing your stem cells, the stem cells that you have left in your body. I put this up there, a playground for creativity, because that's what RECNAC was to me. We were given the freedom to pursue whatever looked promising, and that doesn't happen in many institutions. It was a very unique, wonderful time in my life, and we worked. I don't think there was a day we worked fewer than 12 hours. We were there at 6 a.m. Almost every single day. Worked most weekends, but it was the most fun that I've ever had. And now, hopefully, I've created in my place in Panama a playground of creativity. We have a research team there that has wide latitude on what they're able to do, and I think that is bearing a lot of fruit for us. So, and I want to basically thank my father for that. So my disclosures for conflicts, we have Medistem Panama, the Stem Cell Institute in Panama. The Riordan McKenna Institute is in Dallas, and we do mostly regenerative orthopedics, but Dr. Russell Phillips is here, and he joined us in this year, and he does he does IV therapy, and he does hormone replacement and things like that. And Julie is one of our nurses, is here as well. And also have Aiden Products. And Aiden Products came out of the Riordan Clinic. So when I left, I licensed certain technology, and the technologies were for C-statin and M-kind, which are one's an angiogenesis inhibitor that we did a lot of work on in the RECNAC project, and M-kind is an immune stimulant that we did a lot of work on. STEM-kind was developed after that, but it's actually an extension of the M-kind, and then Inflikine is an anti-inflammatory product that we make. So cells, I'm going to talk about MSCs, and I'll explain exactly what they are. They're mesenchymal stem cells. That's the last time I'm going to use that word. I'm just going to refer to them as MSCs. They're multifactorial, site-specific sensors with genetically wired molecular responses. So MSC cell therapy works everywhere in the body. They will home to any inflamed tissue, and they will act appropriately. So there are two main stem cell types in our body: the hematopoietic stem cells, CD34 cells, which produce all of the blood cells continuously. You know, every minute we lose 15 million red blood cells, and they're replaced by these upstream. The hematopoietic stem cells gives rise to all the blood cells in our body. And then we have the mesenchymal stem cell. And the MSC, I'm sorry, I used it twice. I won't do it again. Okay, so the MSCs are found everywhere in your body. We can get them from basically any tissue. They're found in relatively large numbers when we're young in the bone marrow. And then basically any tissue that has a blood supply has MSCs. So the reason that they're found in every organ is because they're pericytes. They surround every capillary, every blood vessel in your body, small and large. So the interesting thing is that the definition of an MSC is that it can differentiate into chondrocytes, basically into bone, cartilage, and fat. So that's in the laboratory you can do that, but what happens in vivo, they don't do that. They don't do that at all, but that's what you can do in a minimum of 3 different tissues. And we've been able to make 9 different tissues out of them, but that's tissue engineering, and that's not what I'm talking about. I'm talking about just giving MSCs to patients. So really they do 4 things. They control inflammation, they modulate the immune system, and they stimulate regeneration. Those are the main 3 things they do. But one of the craziest things, I've heard a lot of talk about mitochondria here. This discovery was just made a couple years ago. There's a reference to it maybe 6 or 7 years ago, but a group a couple years ago published in Nature, and they showed that the cells actually donate mitochondria to sick cells. So if your cells are sick and you infuse MSCs, they donate their mitochondria. So what's even cooler than that is they triage the cells, and if the cells have enough mitochondria to survive, they'll just pass. They'll just say, "Oh, you're cool," and then if they don't have enough mitochondria to survive with their donation, they just say, "Well, you're dead," and they move on to the next one, and then it's in between, and they say, "Oh, look, I can help you," and they deliver mitochondria. So this is something I said a few years ago, but most chronic diseases are due to a lack or dysfunction of MSCs and other cells, but predominantly MSCs. You can go back to any chronic disease and you can find either a lack of or dysfunction of MSCs. And as we age, that number goes down and the function gets screwed up for a variety of reasons. So the activity of the cells is not them becoming other cells. The activity of the cells is what they secrete in response to what they find when they get there. So all of the activity, so we have data on patients. We're doing a clinical, we have 2 INDs in the United States for treating Duchenne's muscular dystrophy. And we know that the cells don't survive because we have the clinical data. So like we have a patient right here in Wichita we treated 7 times in Panama, and he's been treated here since 2014. by Dr. Strickland, and with our cells from Panama. And at 4 months, you'll see we monitor his breathing, his maximum inspiratory and expiratory pressure are the most sensitive things for how he's doing. And so he gets his cell therapy, and it goes up, and it peaks at 4 months, and then it starts petering out. That's because the cells die off. They're foreign cells, right? So they're immune privileged, and they'll survive in the human body, because these are donated from umbilical cord. They'll survive in the human body for 4 to 8 months. And we know that because of genetic diseases where you see that the benefit goes away. And some people worry, well, what happens to those cells? I mean, is there a big immune reaction? Well, we're only talking about a maximum of 140 million cells. And those 140 million cells, we dispose of, our reticular endothelial system disposes of 15 million red blood cells every minute. So it's a non-event. Like, nothing happens. You just see that the benefit starts wearing off in genetic diseases. So all of the benefits are from the secretions, not from the cells actually incorporating and becoming tissue. So Arnie Kaplan is my sort of my godfather in this world. He gave the name MSC, the mesenchymal. Oh, I said it 3 times. He gave the name to the MSC. He named it. He's at Case Western Reserve, and he continues to plow away in this field. And he actually suggested calling them another name, because since they don't actually act as a stem cell in vivo, he suggested the name of medicinal signaling cell, keeping the MSC. So when they're in the body, and they're in a site of inflammation, they react by modulating T cells, B cells, dendritic cells, T regulatory cells. In fact, that's the major, in autoimmune disease, that's the major mechanism of action, is you infuse IV MSCs, the T regulatory cells go up. And T regulatory cells shut down autoimmune diseases. So they're also anti-apoptotic, they're anti-scarring, they induce angiogenesis. You know, with no blood supply, nothing's going to get better, right? So they induce angiogenesis and they induce mitosis. This is a scanning electron micrograph of falsely colored MSCs surrounding a capillary in the pink there. And these are other scanning electron micrographs of capillaries, and here's a capillary here, and then larger vessels, and you can see that there are MSCs surrounding every blood vessel in the body. So just to give you an example, this is from the body exhibit where they basically rubberize the vascular system, and then they sort of digested everything else away. So you can see that there are basically blood vessels everywhere in our body. So the MSC numbers go down with age at a depressing rate, meaning it depresses me at how few I have right now. So there's not only an age-related decline in the number, but there's an age-related decline in the fitness or the robustness of these cells. And these cells are the major, they are homeostasis for our bodies, right? They are what create homeostasis for the immune system, homeostasis for blood pressure. They are the major modulators of health. So here's a depressing slide. So when you're born, 1 in 10,000 cells in your body in your bone marrow are MSCs, and at the time of skeletal maturity, that's declined by 90%, and that's basically what you got to live on for the rest of your life. Another depressing slide. So if you take cells from a newborn and you grow them in the laboratory, and we do this, that's what we do. We take umbilical cords from live healthy births, from cesarean sections, and the baby's born and delivered, the cord is cut, and then when the afterbirth comes out, then we take the cord from there, take it back to the lab, we digest it, get the MSCs, and we grow them up in large numbers. We have a big screening test for which ones are good and which ones aren't, but so we grow these cells all the time, and the average doubling time is 24 hours. If you take cells from a 35-year-old, the average doubling time is 2 days, 48 hours. If you take them from a 65-year-old, the average doubling time is 60 hours. So that sounds kind of linear, but in the newborn, when we grow those cells up, you can start with one cell. At the end of a month, you have 1 billion cells. And the 35-year-old, you have 32,000 cells. And a 65-year-old, you have 200 cells. So if you need 1,000 cells and you only make 200, we've got a math problem. The regeneration-degeneration axis is tilted in favor of degeneration. So that's why we do what we do. That's why the cells that we use work so well, particularly in an aging population. So we opened there in 2007. I founded a company in 2005 called Medistem, which was technology that we discovered here at the Riordan Clinic, which was it was kind of a contract situation, but we discovered the menstrual MSC. And that was the foundation of the publicly traded company Medistem. We sold that company 2 years ago, but we kept going in Panama with we have a clinical trials company, and we have the clinic and the laboratory down there. And as I mentioned, we have 2 INDs in the United States for Duchenne's muscular dystrophy, and our intention is within the next 12 months to do a full IND phase 2 trial for DMD using the cells. Because they work every single time they're treated, and there have been no side effects. And we've treated a dozen kids with Duchenne's muscular dystrophy, the youngest being 3.5, who's now is in Indiana and is now 7 years old, and you can't tell he has any symptoms of Duchenne's as long as we treat him every 6 months. And our belief is that we'll be able to treat kids with Duchenne's every 4 to 6 months, and they won't ever develop symptoms. They won't go into a wheelchair. And our oldest is Ryan Benton, who lives here in town, and he's 30.5. We've been treating him since he was 22.5. And he's actually in way better shape now than he was 8 years ago. And normally, his normal lifespan is about 25. And his predicted lifespan when we started treating him was 2 years. So these are the conditions that we treat. Oh, thank you. Thank you. I wasn't looking for it, but thank you. So it sounds like a really disparate bunch of diseases here: MS, rheumatoid arthritis, autism, spinal cord injury, osteoarthritis, asthma, frailty of aging. It sounds like snake oil, right? Oh, it treats everything. Well, if you look at the etiology of each of these conditions, the pathophysiology is either a lack of or a dysfunction of MSCs. So in MS and rheumatoid arthritis, we don't treat lupus, but I'll tell you about some studies that are going on in lupus right now. We intend to pretty soon. But those 3 autoimmune diseases are actually very different. Lupus is a type 2, basically too much, the immune system basically make an antibody, so it's a type 2 rather than a type 1. MS and rheumatoid arthritis are type 1. So they're 2 completely different spectrums of the immune system, but MSCs treat them successfully because the MSCs are dysfunctional in those patients. We take MSCs from the fat or from the bone marrow and we grow them up in culture. They don't behave normally at all. Their robustness level is like a 90-year-old's, and they're supposed to be, and these are patients in their 30s, 40s, and 50s. In autism, I'm going to talk about our clinical trial that we're doing with autism, but basically it's an inflammatory disease, right? I mean, I think Dr. Humphreys was talking yesterday about Wakefield, and Wakefield demonstrated that there are these immune nodules in the distal ileum that are producing inflammatory cytokines, which actually go and then a researcher at Harvard showed that those inflammatory cytokines are inflaming the white matter of the brain and swelling the brain, and it's actually a purely an immune problem. And so these cells treat immune problems. Spinal cord injury is excuse me, is a lack, here we go. If you think about evolutionarily, we have we have built this wonderful cage around our central nervous system, our spinal column, and our brain, and our skull, to prevent injury to it. And we didn't, the blood-brain barrier is a very different type of vasculature than the rest of our vasculature, right? It's very tight, and MSCs don't reside there. So it's the one place that the MSCs don't reside, or they reside in very small numbers. So if you have an injury there, there's no MSCs to go fix it. So if you cut your leg, what happens is you cut through a bunch of blood vessels, the pericytes are released, they become activated MSCs, and they repair the problem, right? So with spinal cord injury, they aren't there. So all we do is we put them there. We just put young, healthy MSCs there. Osteoarthritis, there are not enough MSCs in the joints, so we just put them there. With asthma, there are dysfunctional MSCs in asthma patients, so we give them MSCs, and then their asthma goes away. And frailty of aging, that's purely, it's a combination of a lack of MSCs and or dysfunction of MSCs. So we're not the only ones that are interested in MSCs. Here's just on PubMed, if you go on there and type in the word M. This is an annual number of articles that are about the word M. So we collaborate with a lot of universities: University of Utah, Florida, UCSD, Western Ontario, NIH. We have more than 30 publications on stem cells. We have a commercialization partner, Cook Medical, which is a multi-billion-dollar company, and we're doing the clinical trials in collaboration with them. Well, I already talked about doing the clinical trials here. So I think I've already said this, but the cells that we use, because they are the most robust cells that are absolutely proven to be safe, we use umbilical cord MSCs, and these are taken from live healthy births from cesarean, and they're grown in our laboratory. The mother is screened for infectious disease. We have a very strict release criteria for all these cells. We have a selection process. The great thing about having all the clinical data that we've treated more than 5,000 humans, is that we're able to determine which cells work for which conditions. So we have a lot of intellectual property on our selection process. So we're able to select for cells that are very effective for rheumatoid arthritis, select for cells that are effective for DMD, for MS, et cetera, et cetera. So I quickly go through some pictures of our laboratory. We have ISO. We have 2 ISO certifications. We have a GMP laboratory that's actually been built in California. The problem with GMP is it's the paperwork from inception through that has to be there. So we actually had it built at a clean room company in California, and it's on a boat right now going to Panama. So we'll have a full GMP lab there. It gets installed in November, and it'll be certified in January. But right now we have a GTP lab with 2 ISO certifications, and we do endotoxin testing on every lot. We do flow cytometry on every lot. Every lot gets sent out for differentiation studies by independent laboratories to demonstrate that they are truly MSCs. So just some pictures of the lab. And this is just a schematic of how we do it. The umbilical cord, the tissue's dissected. We enzymatically digest it, and we grow up the cells. We get an initial primary culture, and then we expand them from there. This is just a pretty picture. That's the first 4-color picture of a menstrual MSC ever taken, and that's a cell that's about ready to divide. So they're anchorage dependent. They're normally attached to the plates, but when they're going to divide, they let go. They ball up, and that's how they divide. And here's another cell dividing. And here are cells that are in their normal state of adherence. So I heard you, Dr. Ron, talking about mitochondria. It's kind of the key to everything, right? The mitochondrial oxidation it inversely correlates almost perfectly with the maximum lifespan of animals. And there was a study where they actually looked at mitochondrial oxidation in brains brains and hearts, and I can't remember which one this is, but you see the different animals and their versus lifespan. One of them's brain and one of them's heart, and you can see that there's a very, very tight correlation between the lifespan and the rate of mitochondrial oxidation. And this is the other one, which is this brain. Doesn't matter. So I told you before that these cells donate mitochondria, right? So here's the schematic from this paper from 2 years ago. They put lipopolysaccharide down into the lungs of mice, and that causes a real inflammatory condition and destroys alveoli. And then they followed that by MSC infusion into the bronchi, and they looked at what happened. And sure, basically what I described earlier is what happened. They did triage on the cells, and via this connexin 43, they were able to, they lock onto the cell and they dump in their mitochondria. They also, in addition to the connexin 43, the little channel that's formed, they secrete, the MSC can secrete microvesicles which contain mitochondria. And so those microvesicles then can fuse with the cell membrane of a damaged cell, and the mitochondria can be delivered that way as well. They also, in the microvesicles and the exosomes, which are these little particles that are produced by the cells. So if a cell is this big, a microvesicle is about this big, and an exosome is about this big. And the exosomes are actively produced by the cell. The microvesicles are shed by the cell membrane. So one of the things, like mechanistically, for kidney failure, for example, you don't even need the cells. I mean, and we do a lot of work using, we call it magic juice, and somebody changed the title of my talk. It was supposed to be golden cells and magic juice, but I guess that was a little too wacky. So, but anyway, we call it magic juice. It's basically the secretions of the cells, which have all hundreds of different molecules, but also these exosomes and microvesicles. And for example, in renal failure, there are studies showing that the mechanism of action is not the cells themselves, it's their exosomes, secreted exosomes that contain messenger RNA for IGF-1. And that those exosomes are then taken up by the kidney cells, what are they called? The microtubules, or well, anyway, they're taken up by the cells of the kidney, and then that messenger RNA gets expressed, and they start popping IGF-1 up, and then they're healthy again. So the mechanism is not the cells becoming kidney; it's what they've secreted that's taken up by the damaged cell that helps the damaged cell to repair itself. So I'm going to tell a case story. This guy, my dad taught me that if you're going to drop a name, drop it fast and hard. So this is Mel Gibson's dad, the 93-year-old. So I got a call from Mel about 5.5 years ago, and he said, my dad has a bad hip, and you think those stem cells would help his bad hip. And we started talking. I said, well, is there anything, what else is going on with him? How old is he? Well, he's 93. Well, what else? Well, he's healthy as a horse. So, wow, that's great. 93, that's pretty incredible. He goes, yeah, he just got out of the hospital for kidney failure. and they thought he was going to die, and he got out of the hospital. He was at the Mayo Clinic. He's got a little heart failure, too, but healthy as a horse. So anyway, he came down, and he was not healthy as a horse. He was, this was him in a wheelchair. Didn't say one word the entire trip. And he had a nurse with him. His nurse is named Nellie, and she's from Central America, and she's about that tall, and just, she could pick him up, And this was her attitude. This is bullshit. The whole trip, and they were there for like 10 days, and it was like there's Nellie. So anyway, we went ahead and treated him. We had to get medical clearance that he was going to survive the flight. That's what I was most worried about. And the doctor, this isn't being recorded, is it? Oh. So the doctor. the hospital that allows us to use cells, because now in the early days it was pretty hard sell, you know what I mean, to get a hospital to allow you to administer cells in there. The only hospital that lets us do it is a Johns Hopkins affiliated place called Punta Pacifica, and it's owned by all Jews. It's a complete 100% Jewish owned, right? So we were doing the hip injection, and I get a phone call at like 8:30 from Mel saying, "Where the hell's this doctor?" And so the guy, at a hospital it's different, right? Oh, show up at 8, and you know what I mean? But they're not going to treat you till 10. They got to do all their stuff, and you're going to sit in this room and that room, whatever. So it's only 8:30, and the infusion's supposed to be at 10. But he in his mind it was 8. So and anyway, so I call a doctor at home, and he's in the shower, and I'm like, dude, get out of the shower, get your hands out of there. All right, so we got his hip injected, and also gave him several IVs. And 3 weeks later, he was able to walk. They reported he was completely out of pain. And 3 months later, he went back to Mayo Clinic, where they had released him from his renal failure, and he was in chronic renal failure when he was down there. His renal failure was gone, his heart failure was gone, and he was walking, laughing, joking. And I got a call like a month after that, and I'm like, it's like 9 o'clock on a Sunday morning, which is 7 a.m. California time. I'm like, oh, not good, not good. I'm thinking, well, he's dead, And he says, and Mel says, he says, what do I do? I said, what happened? What happened? He said, my dad didn't get up for church. I'm like, well, why? Well, why not? He says, he's never missed church. I said, why not? He said, he's too tired. I said, why is he too tired? He said, he had a wet dream last night. And he says, what do I do? I said, get him a girlfriend. So just to wrap this up, we got invited out there. Mel invited us out. He wanted us to tell all his friends what we were doing, because he'd never seen anything like it. So we got a room at that pink hotel in Beverly Hills, Hilton, I guess. And he had about 70 people come, and we went out and gave a lecture to his friends and family. And then afterwards, we went to the old man's house, to Hutton's house, and Nellie was there, and she says, Dr. Riordan! She can't think of a big hug. And she says, look at this. She says, hair's better. Look at him. Look at him. And she says, get up, old man. Show him how you can walk. So he gets up, and he's walking around, and the guy moonwalked. I can't moonwalk, but anyway, he moonwalked, and then they showed me this staircase, about 80 stairs, and they said, well, that's where he walked down those stairs for his 94th birthday, so which is in August. He just had his 98th birthday 2 months ago. So anyway, that's my Mel Gibson story, or Mel Gibson dad's story. And I'm just finishing a book, and that story's in the book, and Mel was kind enough to basically tell that whole story. So we're currently doing a clinical trial of autism spectrum disorder, and these are right-handed males from the tri-state area between the ages of 6 and 16, and I already talked about the inflammation that's found in the gut that actually inflames the brain. So our rationale for the treatment is, hey, if you've got inflammation, these cells are pretty good at calming it down. Maybe something will happen, right? So there's a study that there's a study, I'll explain it in a minute, but basically they measure these two molecules called MDC, monocyte derived chemokine, and TARC, thymosin related chemokine. So those two molecules are found highly elevated, and they correlate with the severity of the condition. So low, if you have people with mild moderate, they're going to be mild moderately elevated compared to controls, and if they're severely autistic, they're way up there. So we measured those blood levels, and there are a lot of other endpoints, but the intervention is 4 IVs once a day, and we do that 4 times every 3 months. So we're measuring childhood autism rating score, the ATEC, which is autism treatment quantitative, and we also do a quantitative EEG, and we do all these. We do 31 inflammatory markers, but the key ones are the MDC and the TARC. So so far, we've enrolled 33 patients. 13 of them have been completely treated, have completed their 1-year follow-up, and the other 20 are in the next July, I think, of next year, will be completely finished with the 12-month follow-up for all of them. But basically, the only side effect has been pain at the site of infusion. This is just explaining the childhood autism rating scale, which is scored from 15 to 60. 30 is the cutoff rate for diagnosis of mild autism. 30 to 37 is mild to moderate, and above 38 and above is severe autism. So all of these boys have severe autism. So this is the citation for this study where they showed that correlation between elevated MDC and TARC and severity of autism. So this is our CARS, Childhood Autism Rating Scale, after 2 treatments, and we had highly significant improvement in all the patients. We have an N of 11 on this. This is an old slide, but now we have our N is much higher, but it holds true. But after the first treatment, a significant depression and decline in the MDC, and after the second treatment, even more decline. And TARC, the exact same thing. And these are significant levels. So that's what we're doing in autism, and out of the 11 that are finished, meaning they've had the QEEG, they've had everything done on them. 3 of them went from being severely autistic to being mild moderate. 3 of them went from being severely autistic to not autistic, and 4 of them statistically significantly improved, but they didn't fall out. They didn't drop below. They didn't drop a level. And interestingly, the 2 of the 3 that became not autistic were treated first by a guy named Scott Smith, who's a PA, and he used to be with Rosignol. And didn't Rosignol die? I don't know all the specifics of it, but he was with Rosignol in Melbourne, Florida, and then he went up to New Jersey. And so he was up in New Jersey, and he had treated them, and so he got rid of all their heavy metals, and he got them nutritionally optimized. And 2 of the 3 were his patients that became not autistic after the treatment. So orthomolecular medicine is very important in preparing the body. If you have a toxic body, getting rid of the toxins, and if you have a nutritionally depleted body, it's important to get those levels up. So here, this is a study that we didn't do, but this was done on 172 patients. They gave 1 infusion of 40 million cells, and long story short, everybody got better. Nobody got hurt. TNF-alpha and IL-6 levels, if you've heard of Humira, Umbilical, Intercept, those drugs, those are biologics that I think all 3 of those TNF. There's one that's for IL-6, and that's a $14 billion a year industry in the United States right now, just those drugs. They don't drop levels of TNF-alpha like this, or IL-6. So 1 injection, 50% reduction. And I'll show you the graphs. 50% reduction, and then they took a sub-cohort, 30 patients, gave them another shot, and got another 50% reduction of what was there. So a total of 75% reduction with 2 shots. And these shots, by the way, take 5 minutes. It's in the arm, and it's just a slow push, 5 minutes. So for 2 shots, you got a 75% reduction in TNF-alpha and IL-6. And these are clinical scores as well, the improvement in the clinical scores afterwards. And this is the TNF-alpha and IL-6 was after 1 treatment, and then after 2 treatments. And they stayed depressed for quite some time. They followed these patients for 8 months. Uh-oh. I got something popped up here, Dr. Ron.
It's okay on the screen. Will advance.
Okay, here we go. Okay, there's another study, type 2 diabetes, and it's not on our list. We don't treat it. We have only 7 protocols, and all those are passed by the National Ethics Committee and everything. So it's hard for us to add a protocol. It costs a lot of money, it takes a lot of time. But here's a type 2 diabetes study that just came out, and long story short, they gave 60 million cells, roughly. It was by weight, but if you take a 70-kilogram person, that would be 60 million cells. They gave 60 million cells once, and then 4 weeks later gave 60 million cells again. And then they followed these patients for 3 years. So there were significant improvements in postprandial glucose and hemoglobin A1C, but not the fasting glucose. The C-peptide to glucose ratio were both significantly improved. Sorry, not enhanced. So here are the data. This is over 36 months, and the treatment group's in black, and you can see that the fasting C-peptide, the surrogate for endogenous insulin production, goes way up. And you see there's a peak around, for the C-peptide, around 15 months, and there's a peak around 24 months for the ratio. And then postprandial glucose is depressed, and probably your biggest benefit there is around 12 months, and then it starts creeping back up. And then hemoglobin A1C, about 18 months is your best shot, right? So what this tells us is that it would probably be good to retreat these people every year or so. And it may be that even every 6 months you would get better results. But, I mean, there's no drug that does that, but MSCs do that. So just briefly, Dr. Sun, who's a friend of mine in Nanjing, China, has published maybe 12 papers on the treatment of lupus with MSCs. And when I met him maybe 8 or 9 years ago, he was using bone marrow MSCs, and we started talking about umbilical cord, and then he switched to umbilical cord because they're better cells, they're younger. You have to get the bone marrow from an adult, and we've already shown that they're 90% depleted. So anyway, he, because of his work, there is now a 6-center trial that was just put up on, that got an IND in July in the United States treating lupus with umbilical cord MSCs. So we're finally getting there. His work was ignored for many years, and somebody at Medical University of South Carolina took note, and now you have a 6-center trial. I know that Northwestern, Emory, North Carolina are 4. Those are 4 sites. I can't remember the other 2, but it's the level of acceptance of all this is really gaining ground. So as I was mentioning, spinal cord doesn't have very many MSCs in it, so when you cut the spinal cord or you damage the spinal cord, it can't repair itself because it doesn't have the repair cells. So this study was done in 2008 in Taiwan, actually, and they cut the spinal cords, and when they do that, they go boink, and there's a gap in between, and so there's a little cartoon of the gap. And what they did is they took human umbilical cord MSCs and implanted them with fibrin to keep them in place, and they put them at these locations, and what happened was the spinal cords regrew. And the reason this is real important is not just that the spinal cords regrew, but because they were human cells, they could fish for human cells on microscopy later, and they found that, yes, indeed, there were still a few human cells there, but none of them were actually part of the central nervous system. They were just trapped between the fibers. So the human cells did not transdifferentiate. They did not participate at all, other than the secretions that they gave off allowed, induced, or whatever you want to call it, the spinal cord to resprout and rejoin. And then they use conditioned medium from the cells as well, and you can see the cells themselves. This is the control, the spontaneous amount of regeneration, and this is the stem cells. And then they use conditioned medium, or the magic juice, from the cells, and the magic juice from the cells themselves worked as well. And this is data from 50 patients at our facility, and I can tell you that we did a cohort a number of years ago with University of Miami, and if we had patients between 0 and 1 year, 100% of them had restoration of some neurologic function. Between 1 and 2 years, it was 82%, and after 2 years, it was 50%. So the more scar tissue there is, the harder it is to fix. But these are different, scales of self-care improvement. Respiratory, sphincter, mobility, extremity trunk, and pain reduction is number 1. And I'm going to tell you about a case in a minute about a guy that got completely better from spinal cord, and that was the first thing he noticed. The first treatment, nothing happened other than his neuropathic pain went from a level 10 to a level 3. So he was able to get off narcotics. He was on whopping doses of narcotics to control the neuropathic pain. So here's a young man, actually from Puerto Rico, who happened to be in the wrong place at the wrong time, got shot in the back. He was in a bar, and some guy came in and just started shooting it up, and he was shot in the back, and he was completely paralyzed. And this is, his mom sends me these videos, and she said it was okay to use them. And there's actually, I have a picture, the first picture she sent of him, he was flipping her off. So I didn't include that, but anyway, so he's a pretty feisty dude. But anyway, that's the first time he walked, and this is the first time he's able to adduct. And this is the first time he was able to ride a bike. We treat, our star patient is Juan Carlos Murillo, he was a commercial pilot, and he was flying his private plane and crashed it. And both he and his passenger were completely paralyzed. He was paralyzed at the belly button. From the belly button down, had no function and no sensation below there. After the first treatment, and a treatment is 4 weeks. It's not, and it's multiple IV infusions and multiple intrathecal infusions into the spinal column. And after one treatment, he got no function or sensation, but his neuropathic pain dropped dramatically. So he was willing to do another round of treatment. After that treatment, his left leg started working. After the third treatment, his right leg started working. After the fourth treatment, he got his erectile function back, he got his urinary function back, and he could walk into this room right now and you would have no idea that he had a spinal cord injury, a complete spinal cord injury. So we wrote that article. We wrote that up in 2010, and he's been down. He has some atrophy. So what we've been doing is injecting the magic juice into his legs, and particularly his left leg, which was the most affected. And he's gaining muscle dramatically from that. The injury was 6 months and 3 days, and he had I think 2 or 3 surgeries to stabilize everything. So a lot of people freak out about, I'm getting donated cells, and I know you're taught in medical school that even a picogram of a foreign protein can cause anaphylaxis and make you die. Well, these cells are tolerated, right? They're immune privileged cells. They're universal donor cells. I can take MSCs from any one of you, grow them up in the lab, and give them to any other of you without any hesitation that there's going to be a reaction, because these cells do not induce an immune reaction, at least immediately. No, the immune reaction I was talking about later, when they mature and they're cleared out. That's why they're so safe, is because later, if they mature into something, then they start popping off MHC, and the immune system recognizes that and clears them out of the body. So there was a paper in the Lancet in 2004 that showed that mothers have, a baby is 50% genetically distinct from mom, right? MSCs are the reason babies aren't aborted. They're the reason we're here, because without MSCs, the immune system would recognize that as foreign and get rid of it, the developing fetus. So, and a baby is 50% genetically distinct from mom, and yet 50 years later, and they were doing surgery, open heart surgery on these women, and they pulled the bone marrow out, and they found male MSCs in the bone marrow. So up to 50 years later, these cells survive in mom, right? And you'd think, given childbirth and then child rearing being very stressful events, that you might live less if you have more children. Well, actually, the inverse is true. Mothers live longer than non-mothers, period, and mothers live essentially a third of a year longer per child they have, up to 14 years. And then the suicide rate goes through the roof? No, just kidding. I remember being taught that mothers have a higher incidence of certain autoimmune diseases, and that's complete bunk. It's actually been proven in prospective trials that mothers actually have less autoimmune disease, and they thought it was because of microchimerism, having a few of these cells floating around from the baby that the immune system's reacting to. Well, that's BS. Oh, there. Well, I just said that. So a lot of people worry about cancer as well. There's not a single published study that shows that umbilical cord MSCs participate in or enhance tumor growth. The only published literature states that these cells inhibit tumor growth and can completely abolish cancer in animal models. So there are studies of MSCs, not from umbilical cord, but from aged individuals that actually promote cancer growth. So this is we use this is from our FDA IND application where they requested us to look at established tumor growth, and this study was done at the Riordan Clinic. What's the guy's name? Xiaodi, Dr. Han. Dr. Han. And so these were established glioma in rat brains, and then the cells were either given intravenously or intratumorally, 1 shot intratumoral, 3 IV. And what happened was, didn't matter which way you gave them, this tumor shrunk by 50%. And this didn't translate well either. This was done at K-State, and they took a breast cancer model in rats, and where they implant the breast cancer tumor subcutaneously in the groin, and it grows, and then it metastasizes, and it's a pretty rapid deal. And they did the same, they modeled it after our study, and they did 1 shot intratumorally or 3 IV, and it didn't matter which way they gave it, the tumors completely disappeared, and there were no metastases 100 days later. This is a control animal. You can see the primary tumor, and the primary tumors disappeared in the treated animal. And here's the tumor volume data. And you can see that around 18 days, the tumors started disappearing, and they went to 0, and they never came back. So I'm going to switch gears and talk about EPCs for a minute, endothelial precursor cells. They are a subset of their CD. It's not in your syllabus. I changed this whole thing. Sorry. I'm going to take off my coat. So the EPC is a subset of the CD34 cell, which they survey the inner lining of your vasculature, and they repair it. That's what they do. They come from your bone marrow, and as long as they're circulating, you're in good shape. Well, it turns out that if you have any of a number of diseases, you have a lower number of EPCs, and the etiology of that disease may be that you can't repair your vasculature. So, I just said all that. But they home to the injury site, and they repair any damage to the intima, the inside of your blood vessels. And atherosclerosis is basically a lack of circulating EPCs. That's how, if you want to boil it down to an etiology, that's the etiology. So this was a great study of stroke patients where they looked at them and they categorized them into high number of EPCs or low number of circulating EPCs, and the ones that had a high number improved a lot more than the ones that had a low number. So and they were all low to begin with, but the ones that had the highest level of EPCs responded the best. This is a correlation with the Framingham risk score, and there's an inverse correlation between the number of circulating EPCs and your score. So the lower your EPCs, the worse your Framingham score is. This is with Alzheimer's. You've got people with, on the left, you have the controls, and then the Alzheimer's patients are much, much lower. And then also that correlates with the severity of Alzheimer's as well. And then this is migraine headaches. You have people without migraines on the left, people with migraines without an aura in the middle, and then people with migraines with an aura on the right. And so it's boom, boom, boom. This is people with erectile dysfunction, with mild ED, moderate ED, and severe ED. And this is basically an image of all the different things that are affected by low levels of circulating EPCs. So we did a study here. We created a product at Aiden that is called StemKine, and the idea, we tested 60 different generally regarded as safe materials on bone marrow that I got from UCSD that was normal bone marrow that my friend there was cleaning out his freezer, and he said, "Hey, you want some bone marrow?" I said, "Yeah, I'll take your bone marrow." So we tested all these different items like extracts from, you know, blueberry, goji, green tea, everything you can imagine. We tested everything. We incubated that with the cells to see which ones helped the cells survive and to grow. And we got the list down to about 6 items. And the one that actually worked better than anything was our Lactobacillus fermentum extract. So then we wound up making a product where we dumped green tea, goji, and astragalus root extract, and we ferment that. And then that's that's the main product there. And then we add a little bit of vitamin D, because vitamin D is, if there's no vitamin D, nothing's happening, right? And then we also add ellagic acid. We can't add that to the fermentation because it will stop the fermentation. So we add it afterwards. And so we did 2 clinical trials here, and this is one of the graphs from that, showing the dramatic rise in EPCs after taking StemKine. So in summary, I think that a deficiency of or a dysfunction of your MSCs, your EPCs, other cells, other stem cells in your body is the root cause of the majority of chronic illness. And I think that orthomolecular medicine addresses those, particularly the dysfunctions. You can't do a lot about the deficiency, but you can do a lot about the dysfunction. Boosting your MSCs with young cells is probably a good strategy. And I've given you a couple of cases of that. And circulating EPCs are very important to your health. And that's about all I got. Oh, wait a minute. I have 2 books coming out. Got a little sales pitch here. Wait a minute. One of them is STEM, Confessions of a Stem Cell Pioneer, and that should be out in January. And the other one was submitted yesterday, and it's Mesenchymal Stem Cells. It's a review of all published clinical trials on MSCs. So look for those on Amazon soon. Thank you.